chronic renal failure, or over a period of weeks, the client will move from oliguric to the non-oliguric phase of acute renal failure. The onset of the non-oliguric phase indicates the nephrons have recovered enough to resume making urine. In the non-oliguric phase, the client begins to make moderate to large amounts of very dilute urine, usually 1,000 milliliters or more per day. The client is technically still in acute renal failure, and fluid volume and electrolyte problems may develop. For this client, you would continue to monitor for fluid volume alterations, both increased and decreased. BUN, creatinine, and serum potassium may remain high despite diuresis, or the client might lose electrolytes. This phase usually lasts 2 to 6 weeks. The last phase of acute renal failure is referred to as the recovery phase. This phase commonly lasts 3 to 12 months as a client progresses from non-oliguric renal failure to a state of renal function that resembles normal. While fluid volume status and electrolytes are stable, approximately 30% of clients have post-renal failure insufficiency. This makes them more vulnerable to renal dysfunction if re-exposed to pre-renal, renal, or post-renal risk factors. Chronic renal failure is a progressive and irreversible form of renal failure. 60% of all chronic renal failure develops as a result of uncontrolled hypertension and diabetes mellitus. Other relatively common causes of chronic renal failure include chronic disorders such as unresolved acute renal failure, systemic lupus erythematosus, chronic glomerulonephritis, sickle cell disease, and amyloidosis. Chronic renal failure develops in phases. Each phase represents more loss of nephron function and less glomerular filtration. The first phase of chronic renal failure is renal impairment. During this phase, the client has no symptoms, but has lost 40 to 75% of nephron function. The second phase of chronic renal failure is referred to as renal insufficiency. During this phase, BUN and serum creatinine begin to rise. Serum hematocrit begins to drop because erythropoietin from the kidneys is not being secreted and the bone marrow is not being stimulated. Polyuria develops because the kidneys have begun to lose their concentrating abilities. Nocturia develops secondary to the rise in urine production at night because blood flow to the kidneys is improved when the client is in a reclining position. There is a 75 to 85% loss of nephron function during this phase. The third phase of chronic renal failure is referred to simply as renal failure. By this time, serious loss of nephron function and glomerulofiltration has developed. BUN and serum creatinine continue to rise. Anemia worsens, and other such conditions such as hyperkalemia, azotemia, and metabolic acidosis develop. Fluid volume and serum sodium levels vary a great deal during this phase, so you would monitor the client carefully for overload and deficits of fluid and serum sodium. The fourth and final phase is referred to as end-stage renal failure or end-stage renal disease. During this phase, only 15% of nephron function remains and the client's glomerulofiltration rate is 10% or less. There is serious exacerbation of the existing signs and symptoms, along with the development of a fixed specific gravity, proteinuria, and oliguria. You must now help the client deal with additional health concerns brought on by end-stage renal failure, such as alterations in skin integrity and nutritional status, hypertension, hypervolemia, and more electrolyte disturbances. Other problems common with end-stage renal failure include chronic anemia, azotemia, metabolic acidosis, hypocalcemia hydroxycholecalciferol deficiency, hyperphosphatemia, carbohydrate intolerance, hyperlipidemia, glucose intolerance, and